Hi everyone, welcome back. I'm Dr. Linda Chu and we're going to continue our discussion on multi-detector CT of pancreatic surgery, differentiating normal post-op versus complications. In the previous segment, we have talked about some of the early post-op complications, including anastomotic leak and infection. And for this segment, we're going to go over the rest of them, starting with hemorrhage. Hemorrhage is seen in less than 10% of patients following pancreatectomy, but it accounts for up to 38% of mortality. It can be broken down into either early hemorrhage or late hemorrhage. Early hemorrhage in a Whipple patient is usually due to GDA stump insufficiency or technical failure of the surgery. If it occurs more than 24 hours later, usually it's due to development of an ulcer, some pathology that erodes a vasculature, development of a pseudoaneurysm, or anastomotic dehiscence. And when you want to evaluate hemorrhage, there's a variety of CT protocols you can potentially do. If all you care about is to look for a hyperdense fluid collection or hematoma, frankly, you can do it with any of the protocols. Either you can give IV contrast or no contrast. You can see it in all of them. If your concern is potential GI bleed, I would strongly say that you should not give any positive oral contrast, as the presence of positive oral contrast will mask any active bleeding into the GI lumen. And if you want to look for active contrast extravasation, then you need to do a dual phase. And here with our protocol, we do an arterial and venous phase exam. None of the other protocols will allow you to tell that there's active contrast extravasation. And sometimes surgical materials are inherently radiodense. And to differentiate a bleed from surgical material, dual phase is also very helpful. And sometimes in the non-contrast, it can also be more obvious. So in looking at hemorrhage, you're really looking for a hyperattenuating fluid collection. And depending on the protocol that you have selected, you may or may not be able to identify active contrast extravasation. As I mentioned, the main thing is if you are thinking about potential GI bleed, do not give any positive oral contrast. And I do find that sometimes these bleeds can be rather subtle on the axial images, and multiplanar reconstruction and MIPS can be very helpful in subtle cases. And not everything that's hyperdense is due to hemorrhage, and some other materials such as surgical material or medication can also be hyperdense. This is a patient who had a Whipple on the post-op day 3. And even when you look at this case, you can see that there's a lot of very heterogeneous material throughout the stomach. And when you compare the arterial versus the venous phase images, you see this blush of contrast that increases from the arterial to the venous phase images, consistent with active contrast extravasation. And this is the same patient. Now I'm just showing it on MIP images. And you can see that that blush of irregular contrast that is within the stomach lumen. But I think the MIPS can sometimes be helpful in differentiating this surgical material, that you can very clearly see that those hyperdense material are due to suture lines. And this is a different patient who had a Whipple 6 weeks ago who comes in with intermittent GI bleed. And you can see that this is the pancreatic remnant, this is the afferent jejunal loop, and when you look, there is this abnormal contrast collection there, and it's surrounded by a hematoma. And you can also see that abnormal contrast collection on the coronal view, and this is due to a GDA pseudoaneurysm. And sometimes these pseudoaneurysms can be rather subtle on the source images, and these 3D reconstructions can help. In the normal expected post-Whipple patient, you have the common hepatic artery coming through, and they should really clip off the GDA right right up against the common hepatic artery margin, and there really shouldn't be much of a remnant. So if you see an abnormal collection that's sticking out at the where the GDA used to be very concerned about a GDA pseudoaneurysm. This is another patient who had a Whipple, intermittent GI bleed, and it's also due to a GDA pseudoaneurysm. And these pseudoaneurysms can be very subtle, such as this case is only about 2 to 3 millimeters big that you can see on the axial. You can kind of appreciate it on the coronal. Again, you have this abnormal outpouching at the location of where the GDA used to be. And when you look at it on the MIPS, you can see that a little bit better. And hemorrhage can be also due to a pre-existing pancreatic leak because the pancreatic juices are very erosive and they can break down the vasculature. So this person had a distal pancreatectomy with known pancreatic leak, and then now the pancreatic juices have eroded through some of the vessels and now has caused active bleeding along the greater curvature of the stomach. Another dreaded complication of pancreatic surgery is ischemia. So again, depending on how sick the patient is and clinically how they're doing, people may choose different protocols. But I would say if they are really concerned about ischemia, dual phase would be my protocol of choice because we can look at vascular patency. We can see those better than on a single phase exam. We can look at organ enhancement, and we can also see secondary signs of ischemia. But if the patient has really bad renal function or the clinician really just don't want us to give contrast, then we become very limited in that we can't identify vascular patency, we can't tell if the organs are enhancing normally, and we really need to just rely on secondary signs of ischemia. When we think about causes of ischemia, it can be due to arterial thrombosis, venous thrombosis, or even if all the vessels are patent, it can be a global low flow state, and that's referred to as non-occlusive mesenteric ischemia. And the CT findings, depending on whether there's a vascular thrombosis, we may or may not see that, but we'll see other signs of ischemia, including altered organ perfusion, organ edema, pneumatosis, and portovenous gas. This is a patient who had an ampullary cancer status post-Whipple with abnormal LFTs, and you can see this very abnormal enhancement in the liver. And when we look at why, and when we look at the pre-op CTA, the patient had severe celiac artery stenosis. So just remember, when you do the Whipple procedure, you are taking down the GDA. And in this particular patient, because of the critical celiac artery stenosis, he or she is really dependent on this GDA to supply the hepatic artery. So once you have taken that down, patient is susceptible to liver ischemia. A similar patient here, a patient who had a Whipple, had abnormal LFTs. So again, when you look back at why, the patient had median arcuate ligament syndrome. So that means that he is also dependent on supply through the GDA. This is a different patient who had a venous ischemia, patient who had a Whipple, complicated by acute SMV thrombosis, as shown here. And you can see that there's marked bowel wall thickening of the small bowel and colon due to venous congestion. This is another patient who had a Whipple with portal vein reconstruction, however had acute portal vein and splenic vein thrombosis and resulted in a splenic infarct. And just to show you an example of non-occlusive mesenteric ischemia, this is a patient who was after cardiac arrest, and you'll see very characteristically very hyper-enhancing adrenals and small bowel. Another common postoperative morbidity following Whipple resection or other pancreatic surgery is delayed gastric emptying, and that can affect up to 40% of the patients. It is due to localized disturbance of autonomic innervation of the stomach near the operative bed. Patients usually have persistent nausea, vomiting, or need for NG tube decompression. On CT, we will see a markedly dilated stomach, and we need to look very carefully to exclude an anastomotic stricture or recurrence. This is a patient who had PDAC status post-Whipple, post-op day 7, and this is an upper GI small bowel follow-through, and you can see that this is the immediate overhead. We can see that practically all of the contrast sits in the stomach with very little going into the efferent loop. And this is a 75-minute delay. We see most of the contrast is still held up in the stomach. And this is the 210-minute delay. We still have a lot of contrast sitting in the stomach, consistent with delayed gastric emptying. This is a different patient who had a Whipple 14 months post-op. And again, we have marked gastric distension with oral contrast material. So we have reviewed some of these early postoperative complications that usually occur while the patient is still in the hospital. And now we'll switch gears and talk about some of the later postoperative complications, including anastomotic stricture and recurrence. The incidence of anastomotic stricture after Whipple at 5 years is fairly low, about 8% at the hepatico-jejunostomy and 5% at the pancreatico-jejunostomy. But anytime we see a post-op anastomotic stricture, we need to look at the anastomosis very carefully to exclude recurrence as the cause of a stricture. Local recurrence in the remnant pancreas or local regional structures occurs in up to 30% of the patients. The presence of a positive margin increases the risk of local recurrence, and when you only have one exam, it can be very difficult to differentiate recurrence from expected postoperative changes. So comparison with baseline post-op exams and serial exams is very helpful. CT findings that are worrisome for recurrence would be increased soft tissue in the surgical bed. And usually this soft tissue I find has a little bit more enhancement, a little bit more rounded or convex borders compared to just the post-op findings, which tend to be more ill-defined and strandy rather than soft tissue. And we may also see increased mass effect on the vessels with more vascular encasement or narrowing. And we may see new anastomotic stricture at either the PJ or the HJ. And these are sites of local recurrence. Other common sites of recurrence for pancreatic cancer patients would be in the liver and within the peritoneum. The post-op changes, the soft tissue should remain either stable or gradually decrease over time. This is an example of a patient who had a distal pancreatectomy. And when you look at this 7-month post-op exam, you still see some soft tissue at the resection bed. If you just have one exam, it can be rather difficult to tell if this is just expected post-op change or if there's some residual or recurrent disease. But here I can show you the same patient 4 years later, that amount of soft tissue has decreased over time, so we can tell that that's just normal post-op changes. And it's particularly important when more and more of our patients undergo neoadjuvant chemoradiation before surgery. So this is the patient at baseline. You have this locally advanced cancer, and this is the patient after chemoradiation. And you still see this ill-defined collar of soft tissue around the SMA. And this is the 1-month post-op, and you see a little bit of soft tissue near the SMA. Given that the patient had negative resection margins at surgery, this soft tissue is likely due to just normal postoperative findings, but we'll need to follow up to tell whether this is post-op changes or if there could be recurrent disease. And just to show you some examples of proven recurrence so that you can see what that looks like, this is a patient who had an Appleby procedure. This is the 1-month post-op exam. This is the ligated celiac artery, and you see just a small amount of ill-defined soft tissue in the pancreatic resection bed. Hard to tell if that's just post-op or recurrent disease. But when you look at the 6-month follow-up exam, you can see that there's increased soft tissue in the resection bed. And then when you look in the 18 months follow-up, it's even more obvious, and now you have lost the fat plane with the SMA. This is another patient who had later on recurrent disease. So this is the first initial 1-month post-op exam after Whipple. I would say it looks pretty good. Everything looks pretty clean. And this is the HJ here. So minimal soft tissue at the resection bed. So things look pretty good. Unfortunately for the patient, on the 7-month post-op exam, you see that there's more soft tissue centered at the hepatojejunostomy, more biliary dilatation compared to the baseline exam, and this is due to recurrence at the HJ. This other patient had recurrence at the gastric jejunostomy, in which you would notice that there's moderate dilatation of the afferent loop, and when you trace the afferent loop to the anastomosis with the stomach, you see that there's this enhancing soft tissue mass right along the suture line. And this is causing some degree of obstruction, causing afferent loop syndrome. Other sites of common recurrence for pancreatic cancer patients would be in the liver. This is a patient who had a Whipple and resection of a solitary liver lesion. And on the 6-month post-op exam, there are numerous new liver masses consistent with metastatic disease. And the third site that we need to look very carefully is along the peritoneum. The same patient that I just showed you on the 6 months post-op has a very small amount of soft tissue thickening and stranding along the peritoneum. It may be hard to tell at this point, but then a few months later, it's a lot more obvious where you see discrete nodules along the peritoneal cavity, consistent with peritoneal carcinomatosis. And the tricky thing with carcinomatosis is that not all peritoneal nodules represent peritoneal carcinomatosis. This is a different patient who had a distal pancreatectomy 1.5 years post-op, and we see that there is this soft tissue nodule in the left upper quadrant. Patient even got a PET to show that it was not FDG avid, and this was just a splenule after patient had distal pancreatectomy and splenectomy. Another mimicker would be fat necrosis. This patient had a Whipple 3 years post-op, and we see that there's this soft tissue nodule within the omentum. And when you look closer, you can see that there's some internal fat density within this soft tissue nodule. So it looks a little bit different from the other cases of peritoneal carcinomatosis. And when we look back further in time, at the 1-month post-op exam, we noticed that this was a large area of omental infarct. So this was just an involuting fat necrosis over time. So within these past 2 talks, we have gone through some early and late postoperative complications following pancreatic surgery, and I hope that I have provided some representative examples and some tips on differentiating some post-op complications versus normal post-op. In conclusion, CT is the modality of choice in detecting post-op complications following pancreatectomy, and awareness of the normal post-op anatomy and CT findings are key for detection of post-op complications. And thank you very much for watching. I'll see you next time.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.